Welcome to today's lecture. My name is Tim Knott. I'm an ophthalmologist based in Bristol, working for the Rovet Group for Rovet Referrals. And today we're going to chat about how we're going to use our smartphones as a clinical tool in photography. We're going to try and show you how our cameras and our phones can be used not just for taking photographs of the whole patient and close-ups of the eye, but also as effectively digital ophthalmoscope. Any questions, queries, please WhatsApp me or ring me. My number's on the screen, or you can email the entire team on eyes@rovetgroup.com. So this little video clip here we're showing you is the optic nerve head of a normal dog. If you look closely, you should be able to see the pulsing retinal arterioles, and these images should be easily accessible with most mobile phones. So we're going to give you a few tips as to how to get them today. There's lots of ways we image the eye in ophthalmology, and more and more exciting as every year passes by. This is an example of some of the tools we get to use at the eye clinic. This is an ophthalmic microendoscope. As well as being a microendoscope, it also has a laser built in. This thing's about the same size as a 21 gauge needle and has both laser, light and imaging. And we use it for lots of different reasons, but particularly for this procedure called endoscopic cyclophotocoagulation. This tiny endoscope goes inside the eye. We can image the tips of the ciliary processes, and using a laser we can shrink down individual heads of the ciliary processes, and therefore aiming to titrate the amount of aqueous humour being produced in the eye. This technique works well in the very, very early cases. By the time we see dogs with a fulminant glaucoma, unfortunately for those eyes it's much less effective. We have to resort from older fashioned techniques such as this silicon tube, this shunt in the anterior chamber. We can also use, this is an ophthalmic biome we attach to our operating microscope. It allows us to look at the back of the eye, the retina. This is a dog with a retinal detachment. We're about to go ahead and reattach. And this little lens you can see here is it's like the indirect lens you'd use in indirect ophthalmoscopy, which we're going to use. We're going to talk about later on today. This is indirect. This is live indirect imaging of the retina for retinal surgery. But we also have incredible ultrasounds nowadays. This is an ophthalmic ultrasonic biomicroscope, 50 megahertz. It allows us to see desmoid membrane, individual cells in the epithelial layer. This is actually an iris, a corneal cyst, an epithelial inclusion cyst. We can image within the corneal stroma itself. We use it occasionally for things like this lump, more often for looking at the drainage angle and looking at the ciliary cleft to try and see if we can understand more about glaucoma, which is our most difficult disease to manage. As well as imaging the eye, we can assess retinal function by measuring electrical activities. This little lemur we looked at the zoo a few years ago. Other exciting things we get to do, and new techniques you might not be aware of, and hopefully we'll talk about it in the lecture, is corneal cross-linking, where we use a combination of ultraviolet light and riboflavin to change the physical structure of the collagen within the cornea. This little French bulldog we'll see again very briefly later. This during treatment. Finally, one of the exciting things we get to do is to do corneal transplants, true corneal transplants. This relies very much on our donors. This is a little dog who's had severe corneal scarring, which is blinding. We've removed the area of opaque cornea and replaced it with a graft, restoring vision. So it can be a very successful procedure, but it does rely on our donors. And we have a gift of sight scheme based in the Southwest. So anyone in the Southwest who wants to get in touch to talk about how you might involve your patients, please do so. However, today's really about imaging, and although we have all these fantastic, fancy pieces of equipment to allow us to do amazing things, most of what I can do nowadays, in terms of diagnostics anyway, I need my reading glasses, particularly as I get older, some sort of focal light source. That could be a simple pen torch with a light on my phone, an indirect lens, a magnifying lens to put onto my smartphone, and something as simple as a Shiot tonometer to measure pressure. With these simple pieces of equipment, we can do most of our diagnostics. However, the most important tool in our armory is our own eyes, and just remembering to look at all of our patients and think about their eyes based on an understanding of the anatomy and the physiology of our patients' eyes. We can get a lot of information even without any instrumentation at all. Other pair of eyes, more now as every year passes than ever before, are the phones on our cameras. And what's really made the difference, that you'll come on to later, is the position of this light relative to the camera. And on all phones where the light is closer to the camera, particularly in the really early phones like the iPhone 4 and the iPhone X nowadays, you can if you can get a light close to your camera, you start to use your phone like an ophthalmoscope. Looking at the eyes are important, not just when they present to you in the clinic with eye problems, but it's part of your normal clinical examination. Looking all the time will help you avoid ophthalmic disasters. Only today, what we're going to talk to you about is how to look at the eye, how to image the eye, to help you using your smartphone to help. So before we go on to how we use our phones, we're going to remind you how we use our current instrumentation, both distant direct, close direct, and indirect ophthalmoscopy. So a quick sort of run through ophthalmoscopy for you. This left-hand image is a feline fundus captured with an iPhone using an indirect lens. This beautiful photograph on the right-hand side from my colleague Josephine is showing the concentric layers of the normal lens of a horse using her iPhone 5 with the light on. So the first technique we're going to talk about is distant direct ophthalmoscopy. This is one of the most useful techniques in ophthalmology. It really is your 5-second ophthalmic overview. In every case you see, regardless of its presentation, you should be doing this technique. This should be quicker than auscultation, and to give you lots of information. If you look at this Labrador in front of us, we can see the left eye has got a lovely tapetal reflection and there's a dark shadow within it. The dark shadow within a tapetal reflection tells us the light is being blocked. That can be a corneal opacity, or lens opacity, or even something behind the lens. Now, if you look at this opacity closely, it's towards the nose side of the pupil, and as the dog moves, it moves right towards the pupil margin. If I flick backwards and forwards, you can see that opacity is moving. And that very simple change, as the dog moves very slightly, tells me that opacity must be behind the pupil towards the back of the lens. And when we look closer, by zooming in with our digital the smartphones, we can actually see this beautiful triangular type lesion, which is typical posterior polar subcapsular cataract in this dog. So from a distance and that moving image, we can learn a lot about the location of our lens lesions particularly. So some concepts to help us get the hang of how this works, which we'll keep going back to, is we're going to run through for you now. So the visual axis is the first thing to think about. The visual axis is that column of light, which is what we call the primary gaze position. It's the direction the dog or the cat or rabbit or horse or whatever stimuli is looking at. Light is passing directly through the axis of the eye, through the cornea, through the clear aqueous humor, through the lens, with this clear lens capsules, clear vitreous, hitting the retina, and that light will bounce back. So this clear column of light is our visual axis, and we're going to use that visual axis to learn lots about the normal function of our patient's eyes. So how do we do distant direct ophthalmoscopy? The first thing to do is to use our ophthalmoscope set on 0. This is an old ophthalmoscope, and just to show you, this is in the 0 position. That means there's no lenses in that whole viewing window. So the alternative is to use a light source as close to our visual axis as possible, and that can be our smartphone camera, or it can be just a pen torch held close to our ear, or a thin illuminator. Once we've got our light getting really close to our visual axis, either through our ophthalmoscope or holding a light next to our eyes, we can start to go through a series of tests, if you like. The first thing we're going to do is we're going to use the ophthalmoscope as a pupilometer. so to measure the pupil size and symmetry, shape and response to light. And then we're going to go on to think about how reflective the fundus is and whether that's symmetrical, and then look for opacities and refractive oddities in the visual axis. And then at the end, we're going to think about opacities outside the visual axis. So this is two cases. This is myself looking at a horse, and my colleague Elena, who's now back in Valencia in Spain with her little dog Bola. And then head nurse. So what we're doing is an arm's length technique. We're holding our patients gently with the hands either side of the eyelids to gently open them if need be, but to sort of encourage the dog or the patient to look towards us. The ophthalmoscope is close to our eyes. And we're looking with no diopters, 0 diopters, and the light on the instrument, and we're looking for tapetal reflections. And within that fundic reflection, we're going to look for opacities and also assess the pupil size, shape, responsiveness. So this is how we use this as a pupilometer. This lovely little cat here has clearly got something wrong with the right iris. It's a very peculiar colour. It's a sort of browny, orangey red colour instead of the lovely yellow from the normal eye. And we're using our light arm's distance. The light is big enough to cover both eyes at the same time to allow us to see both tapetal reflections. And then we're going to assess those tapetal reflections. That's much easier if we turn the lights off, in the room lights off that is. And we can see here we've got two beautiful, symmetrical, shaped and sized pupils, and the tapetal reflection is equal and normal as well, which gives us, even though there's iridal changes in this cat, that gives us lots of reassurance that there's no lens changes, no vitreal changes, and no retinal changes either. Just a note is that the cat's tapetum is much brighter than the dog's, and a normal cat tapetum would be expected to be much brighter than a dog. This dog here has got a hyper-reflective tapetal reflection, and this dog's got retinal degeneration caused by PRA. The tapetal reflection is very important, and we're using that particularly during distant direct technique, and it's important to realise it will change depending on the direction of gaze. This little puss cat on the left hand side is an Abyssinian. Abyssinians and sadly get an inherited form of progressive retinal atrophy, and this cat's got that disease. When she looks straight towards us, we've got this lovely bright green reflection caused by a loss of retinal thickness and increased reflection through that thin retina. But when she directs her gaze slightly away from you, it turns this duller blue colour. So when you do distant direct, talk to your patients, whistle, click your tongue, get them to look at you, and you will see that will give you more information than just a single look. It's my own dog Peggy, a lovely little pug. And when she looks straight towards me, we get these beautiful bright tapetal reflections. They're circular, they're equal, there's no dyschorrhea. When she looks away from me, rather than the bright bluey green colour where the tapetal fundus is being reflected back at us, we get this brown and pink view, which is actually she's looking away from us, and actually is this light reflecting off of the edge of the optic nerve, and the non-tapetal fundus is inverted because of the optics of the eye. So what we're seeing here is the non-tapetal fundus and the optic nerve head, and the tapetal fundus would be down here. In terms of where it actually moves away from us. Now this little puss cat is a different puss cat here, who's also got some changes to the iris. We've got some rubeosus iridis, we've got some hyperemia of the iris. Also we can see some grey splodges. Now these grey splodges are actually on the back of the corneal endothelium. These are keratic precipitates, or KPs, one of the signs of anterior uveitis, chronic anterior uveitis in the cat. Now this little cat on the left of the black cat, we had lovely, nice normal tapetal reflections. We turn the lights off into distant direct. We look at this paler cat, we're going to see some different pathology. So this little cat, sadly, as well as having anterior changes, having pus on the back of the cornea, she's also got inflammatory deposits on the back of the lens at the equator. We call this snow banking. Now, when we look directly through her pupil, we see these little black dots here are shadows caused by the chromatic precipitates on the cornea. If we angle the cornea, the view downwards, we start to see these black chromatic precipitates on the cornea are still visible, but now we can start to see this faint shadow behind, which is the peripheral lesions we're starting to see. And as we angle even further, we're going to see much more of this snow banking, these peripheral lens lesions, and the corneal lesions start to move away from the middle of our view. It's very useful for our patients who are perhaps less compliant. This is a tiger we dealt with many years ago down in Devon, and through the bars of the cage we could get a lovely photograph with speed reflection, which shows us all these lesions which are actually cataracts. These are immature cataracts caused by the incorrect milk replacer in this beautiful large cat. This is another large cat. This is a photograph sent to me from South America, and by zooming in the photograph I can see the speed reflection here, and here there's something very odd about it, and this is actually a luxated cataractus lens behind the pupil. So you can get lots of information from our photographs, particularly when we've got the lights on and allowing us to see the speed reflections. So that's distant direct ophthalmoscopy. You're probably more familiar with close direct ophthalmoscopy. That's how we were taught to look at the fundus, the retina. This is Elena again with her little Bolla, and doing this technique correctly, getting close to her eye, close to Bolla's eye, resting her fingers on Bolla's face so that they're all one unit, so they move together. The close direct ophthalmoscope concept was invented by this guy here, Charles Babbage, who was the inventor of the first mechanical counting machine, the precursor of all computers, and ultimately our smartphones as well. And his first direct ophthalmoscope was a simple brass tube with the patient's eye to the right, the observer's eye to the left, a hole in the side of the tube to allow light in, a mirror at 45 degrees with 3 little tiny holes scratched in the mirroring, so you can see through those holes. Light would pass through the window, bounce off the lens, so the mirror, pass through the pupil of the patient, and he can observe the retina by looking through those holes. A very simple technique. That's really how our ophthalmoscopes and our cameras work to image the fundus. So to image the fundus with close direct ophthalmoscopy, all we really need to do is get our eyes really close to a patient, and then somehow get light to come the same axis as our view through the pupil to see the retina. We do that with our ophthalmoscopes using a mirror. You then, as we just chatted about in Charles Babbage's prototype ophthalmoscope, that's exactly the same concept we use in a modern ophthalmoscope as well. Modern ophthalmoscopes can also have diverging and converging lenses, which we can use to bend the light by adding in positive lenses, converging lenses, such as this 12 diopter lens that allows us to focus not to the retina but further towards the middle of the eye, in this case at the back of the lens. And a stronger lens still, it's a 15 diopter lens now, and we can now bring that divergent light closer again to the observer to look at the front of the lens capsule. And then we put our highest magnification lens is 20 or 40 depending on your ophthalmoscope, then we can start to see the cornea itself. With the fundus, we really need no lenses at all. We're just relying on the optics of the dog or the cat to focus that light for us on the fundus. And this is exactly how our cameras work. So we're getting our phones really close to the cornea with a light which is close enough to the camera that it can pass through the pupil whilst we can still see. Then we can see these beautiful images we can see in the left-hand side here. And you can actually you can see, look carefully, the retinal artery pulsing. This is the non-tapetal fundus, which we saw in Pagu's eye on the edge of the optic nerve head. Whereas what we're really interested in terms of a visual point of view, is the tapetal fundus. This is where most visual acuity is in our patients. So here's the retinal artery pulsing. The dog obviously moving around as we video. Finally, as we talked about distant direct ophthalmoscopy, close direct ophthalmoscopy, now we're going to talk about indirect ophthalmoscopy, which is the mainstay of retinal examination for most ophthalmologists. And for this, we need a diagnostic lens, usually a 20 diopter lens, sometimes 30. Ones we tend to use in our clinic is the pan-retinol 2.2, which is has a very good optical quality, but most 20 diopter lenses can do a good job. And as you see in this little GIF on the left-hand side, as the lens moves slightly, we start to get aberrations. And the better quality lens you have, the fewer aberrations you'll get. You can also see some scratches on the surface of this quite tired 20 diopter lens. These two photographs on the right, a friend of mine from Tehran, Uman, who's taken some beautiful pictures using his iPhone X. The iPhone X, the light is very close to the camera. It's a very good quality camera, and in a dark room with his indirect lenses, so it's beautiful photographs of his patients. Thank you to SIVA for their beautiful book, which is supporting the use of amlodipine in feline patients in feline hypertension. And they very rightly have identified that the eye is a target organ for feline hypertension and the importance of ophthalmoscopy. So they've got a very good atlas, which I'd encourage you to get, and please get in touch if you haven't got it. We can point you to the right people at SIVA to get you one. And they talk in there about how to use direct ophthalmoscopy and how to do indirect ophthalmoscopy. But more than that, they've got a wonderful atlas of images. So in terms of how to learn, please getting hold of that atlas. It's a great help. We also designed some 3D printed training eyes, which you can print yourself if you have access to a 3D printer, or you can contact ourselves, and they can be rented or purchased from myself. And these lenses allow us to practice both photographing and using our indirect lenses and direct ophthalmoscopes for imaging, not just the fundus, but lesions within the lens and on the surface of the eye as well. So watch this space is reminding that we hope to be doing some once we're allowed to get out and about again, some road shows with SIVA. We did some before COVID hit, and it was a very successful meeting where we used the models to teach students how to use the indirect ophthalmoscopy as well as other techniques. So how do you do indirect ophthalmoscopy? It relies very much on its visual access. It's an arm's length technique, so I'm a long way from my patient. You've got a lovely tapetum reflection as the light passes, either with a light beside our ear or a head-mounted kit set, or even a head torch. And then we add in a 20 diopter lens. When we add in that lens, the reflected light from the eye refocuses to form an image, a virtual image in front of the lens. Why we call this indirect ophthalmoscopy, because we're examining an indirect view of the retina, and it gives a much larger field of view, approximating to about a third of the back of the eye, which is that's the best part of 60 degrees compared to it's only 3 or 4 degrees of that direct ophthalmoscope. So this is we met this little patient before, so using my phone, we can with the light on continuously, we can then use the light from the phone to image the retina through the indirect lens, and obviously record it for record keeping, to show owners to seek advice if you're not sure what you're seeing. At the side, if you've got the Panoptic ophthalmoscope, this is a wonderful instrument. They quite often get bought and popped in the cupboard because people forget how to use them. They're a type of indirect ophthalmoscope. They're much easier to use than the traditional lens. They can give a very good image of your patient. So I think it's worth, if you have one of these instruments, it's definitely worth digging it out of the drawer. Your lens is very useful for small pupils, and even this is a squirrel we examined, and even a squirrel, even with an eye this small, we're able to see the very interesting fundus of this very small creature. Now, if you're using direct ophthalmoscopy, so if you're using your phone to examine the retina directly as you would your ophthalmoscope, then the field of view you see will be determined by the lens on your camera. And some of your cameras nowadays will have multiple lenses, 2, 3, even 4. Some of those will be wide-angle lenses, some of those will be telephoto lenses. And the wide-angle lens, the wider angle lens you have, the wider view you'll get. This is from my iPhone X with a telephoto lens, and we can get a similar wide-angle view with close direct ophthalmoscopy as we would with our diagnostic lens, which is in contrast to when we use our ophthalmoscope to do close direct ophthalmoscopy, where we only see a very few degrees. So that's an intro as to what we're hoping to achieve. So we're going to rush, before we actually go into the technique itself, we're going to run through some photography basics. So we chat about focus, exposure and depth of field, and see if we can get the hang of those concepts, which will could take some more useful images when we get to our patients. So focus first. Focus is the most important thing. Lots of images that are too dark, too light. We can get information out by playing with the images on our cameras afterwards. However, if it's not in focus, we really are going to struggle to get much useful information about it. To remain in focus, the most important thing to remember is not to get too close. Your cameras will focus automatically. They're very good at it. But what they can't do is focus too closer than the minimum focal distance. So knowing how close you can get your phone to your patient will make a massive difference to reducing blurry photographs. You can also, camera shake will also cause blurring. So if your shutter speed is too low, the movement of your hand will cause blurring. Again, that's very difficult to rescue in post-processing. The most common reason for camera shake would be not enough light in the first place. If you haven't got enough light hitting coming back from the eye, then the camera will have to lengthen its shutter speed to try and keep it exposed, and you'll end up with this blurring. But the most important thing, the key point, is to know the minimum focal distance for your phone camera. So focus. Exposures next. So exposures can be how much light we get. Is there too much light or not enough light? Key point here is to remember that our cameras, sensors are much more sensitive than our own eyes, and they can see much more than we can. If you have a dark image will often carry lots and lots of information which we can't see, but when you lighten those images up, you'll start to see. This is a picture of a cathedral in France, which I took late at night with my iPhone, with no flash, because the flash is too far away for the flash to be useful, and a little bit of post-processing, just increasing the exposure and changing the contrast. We get lots of detail coming out from this image, whereas if it was an overexposed image, then it's very difficult to rescue data. So dark images will tend to carry more information than light, and you can rescue that by playing with the contrast and brightness, particularly afterwards. Ideally, you want your picture to be exposed properly in the first instance. So if you are struggling to get a nice, well-focused, well-exposed image, the first thing to do is to add more light. That can be by getting closer, using the light on your camera, or you can be using a pen torch held from the side. The second thing you can do, if that hasn't helped, is you can try and decrease the shutter speed. You can make the shutter stay open longer, usually really is adding light is the key. And finally, we can change how sensitive the camera sensor is to light by altering the ISO. The shutter speed and ISO are two things you can change in certain camera apps, but most of the time it's about adding more light. In terms of adding more light, this is an important concept to remember, is that the intensity of light is proportional to the square of its distance. It's called the inverse square law, which means that if you halve the distance between your patient and your camera, then you're actually going to increase the light by fourfold, and not half. But remember not to get the light too close, because you'll end up with blanching out all this information. Finally, depth of field. Depth of field is affected by magnification, and the more magnified we are, the narrower our depth of field will become. Without magnification, depth of field rarely affects our photographs with our cameras, but when we come on to talk about how we use our macro lenses, then it will become very, very important. So this is a picture of one of my colleagues, Matt's. This is a little leopard gecko. He's focused beautifully on this nose, but you can see his eyes are way out of focus. When he focuses the eyes themselves, we can get the iris and pupil in focus in this beautiful macro photography. But you see that the tips of his upper lid are out of focus. So that depth of field becomes very, very narrow as we increase magnification, and we see that with slit lamp biomicroscopes, which is one of the tools ophthalmologists use routinely, and one of the skills we have to learn with that instrument is to be able to move that instrument backwards and forwards in millimeters and sub-millimeter distances in order to focus on the front or the back of the cornea, for example. This is a lovely example of how depth of field, how now the depth of field can get, and how it can also help us to understand the three-dimensional nature of our photographs. This is a horse, so we can see the drainage angle here. It's called the grey line, these are open pectinus, and we're clearly focused on the edge of the iris, the grey line, and the edge of the eyelid. Or as the eyelid comes towards us, we see it comes into focus, and this lovely sort of swirling area here is the tear film, which sits between the eyelid and the cornea of most of our patients. Depth of field can be difficult if you're working in extreme magnification, and there are some tips to be able to to get more information out rather than just sort of struggling to get your one image. So you can take multiple images. You can also use live view, which many cameras use now, where you actually take a short video clip, or you can take video itself. If you have multiple images and you save them to your Google Photo drive, Google Photo will automatically put similar looking pictures into what's called an image stack, to run these little tiny video loops, which will actually allow you to understand the anatomy very, very well. These are the granular iridica of a horse. These are built-in sunshades at the top part of the pupil. And you can see as these stacked images move through their little cycle, we can see along the top of the granular iridica to the beautiful iris architecture, the vessels, and the exposed iris stroma. But the difference in focus between these various areas is only a matter of a few millimeters. So when you're working magnification, you need to be able to use very small hand movements to focus on the bit you really are interested in. This is an extreme example. This is using a 10 times macro lens on my iPhone, and this is looking at the eyes of the giant house spider. And you can see beautifully in focus on his eyes and the legs in the same focal field. As his legs come towards me, they rapidly lose focus. And this little guy looks terrifying. Maybe he was only about the size of my large thumbnail. So why do you want to use the smartphone to image the eye? And how exactly does it work as a digital ophthalmoscope? That's what we're going to explore next. So it's all about the magic of the fundic reflection. We've talked about the visual axis, to how light will pass through the transparent structures of the eye, and we examine the reflected light. And the normal eye, where everything's there's no pathology with a clear cornea lens, vitreous, then it should just be a beautiful but uniform reflected colour. But when there's pathology, then things start to come to life. This patient here has got multiple changes in the lens. We can see these individual linear lesions are individual lens fibres within the anterior lens, which are becoming abnormal. We can see some posterior lens changes as well, and we can see these beautiful bubbles which are in the equator of the lens. We're looking obliquely across this dilated pupil's eyes, dilated pupil, and all these bubbles are individual lens fibres which are really struggling to change, as they should grow into long linear lens fibres. And these lens vacuoles, particularly when they're in the equator of the lens, are worrying that they are maybe a sign of progression of cataract. The right-hand image shows a patient who's had a corneal surgery. We've removed an area of cornea, superficial cornea here, called a superficial keratectomy. You can see that this is an area of vascular cornea that's bleeding from the cut vessels, and we can, by using the tapetal reflection, we can learn lots about what's going on in this cornea. We can see the corneal stromal blood vessels are dramatically highlighted by the tapetal reflection. We can see the edge of the keratectomy very easily. We can see that light passes nicely through the keratectomy. There's an area here, this white area, where light is passing less freely, which might be an area of corneal infiltrate. So in order to get the a good fundic reflection, the important thing is to be able to have incident light, the light we're going to use to get the reflection to be as close as possible to our visual axis. And in ophthalmoscopy we do that by using a little mirror, looking through a very small observing hole. But with our cameras, it really is the issue is about how far our lens is from our flash. So with a compact camera, which you may have in somewhere at home, then you often have a flash very close to the lens. And our compact cameras are often very good for getting those lovely fundic reflections and then the detail we talked about in the previous slide. Whereas if you've got a camera with a pop-up flash, which is on the top of your camera, then that distance, this angle between the instant light and our visual axis is often too far to get good fundic reflection. So you want your light to be as close as possible to the lens. Now, as you move your camera further away from the patient, then your angle of the difference between the angle between the light and the visual axis will get less and less and less. So if you do have a camera a phone camera where your light is a bit further away from the lens than you might like, by taking a photograph from further away, you'll get a better fundic reflection. So just an example of how the difference is. This is a camera with a pop-up flash. It's 85mm from light to camera. This is my lovely Canon Nixus, and this is just over an inch, and this is what I used to use for taking photographs of lens lesions. But the iPhone X is currently my favourite phone camera for taking intraocular images, because this distance here between the two lights, either the telephoto or the wide angle telephoto lens, is about just over half a centimetre, which means that as long as your pupil is that size or bigger, you'll be able to get a fundic reflection. Now, a dilated dog or cat pupil will be about 6 to 7mm in diameter, sometimes a little bit bigger, which allows you to get a really good fundic view. Without tropicamide, without dilation, then you will struggle to get a really good image with any phone camera. So you really need to have a big enough pupil. For large animals, alpacas, horses, sheep, cows, then much larger eyes means that even with undilated pupils, you can often get a really good view of the fundus. So we can use our phone as a fundus camera, either by doing direct, mimicking the direct ophthalmoscopy technique, so getting our phone really close to the cornea without any lenses at all. This is an image of a horse, showing it's a normal horse, but without much pigment. You can see retinal vessels and vessels within the choroid. Or we can use the phone to image the projected image in front of our indirect lens. As we saw in Human's photographs before, this is a dog, pan-retinal lens, which we are using to image the fundus here. Both techniques are very helpful in dogs and cats. Using the indirect technique, trying to image the projected fundic view from the lens is often easier, unless you've got a fully dilated pupil and the patient is going to sit still for you. So what's the best phone for imaging the eye? The one you got with you. So any phone you have will help you to take clinical images. If your light is further away from your lenses than these iPhones. Then if you get further away and zoom in with digital zoom, then you should be able to get similar images. My current favourite is the iPhone X. The iPhone 7 and 8 have these slightly different arrangement of lenses, and these are really helpful for macro photography, we're going to talk about later, because actually we can put a macro lens on this camera lens here, and then use this light to illuminate the image, we'll talk about in a moment. We have a website called theiphone.com, so please check that out, and that'll give you some ideas about how to do it, and talks about apps which we like, and review some of the cameras out on the market. So how do you start off? Well, the easiest way to start is to use video mode. The problem that you have with your normal camera app is that most camera apps won't let you have the light on until you take the photograph. So you can put the flash on, but it's only when you actually hit the button that the flash goes off, which doesn't help us to examine, actually identify the lesion. However, if you put your phone into video mode, turn your light on, when you start recording, you'll get your light on at the same time as you're recording your image. So I'll show you what that looks like. We met this patient before. We saw the vacuoles in the equatorial lens. We saw the anterior lens suture lesion. Here you can see it's an upright Y, which shows us the front of the lens, and an inverted Y at the back. So when you have the light on your video mode, you can zoom in to get the funding reflection to fill the entire image, and you should move around as well. By moving around, you see how these opacities all change into position relative to each other, and that helps us to understand their anatomy. Now when we get really close, we can actually start to see the retina. This horse has sadly detached the retina. We can see the non-tubular fundus here, there's the optic nerve, and we can see the torn, folded up retina around it. So your best starting point is to just use your whatever phone you have with the video mode and the flash turned on. Also, don't forget that you can use your phone to record down your lab microscope, and that's really helpful for demonstrating to owners your cytology, be it anesthesia from the ear, or with aspergillus from a corneal scrape with this little dog which had a fungal keratitis. This beautiful image here is down the microscope. This is tear phoning. This is where we take a tear sample, put it onto a microscope slide, and let the salts crystallize. As they crystallize, the mucins, the nucleus molecules, will their length and their regularity, so are they all the same or different lengths, will affect the pattern you get. And this beautiful tear filming pattern is related to tear film quality. So this is David's photograph, and we can see this branching filamentous septated hyphae, which is very typical of aspergillus, which we then subsequently grew. So iPhone.com, theiphone.com is a good place to go, because I try and keep that updated with which apps work best. For iPhones, then the best app at the moment is Pro Camera. It's a bit more complicated to use than the Camera Plus, which is the one we've used for a long time, but it allows you to change the intensity of the light, which is very, very useful. Camera Plus, either Camera Plus or Camera Plus 2, a little bit cheaper, a bit simpler to use, but you can't change the intensity of the light, so you have to start using some sort of diffuser. We use tape. For Android users, Open Camera is a free camera app. Is very good, as is DSLR camera as well. They're both free apps. So some basic skills for using your phone. Most important one is to know your minimum focal distance. The second is to know how to focus, and ideally to learn how to focus manually and also using the autofocus. The third important thing is to know how to get the light on whilst taking an image, and with your basic camera app that's usually not possible, but with some of these third-party apps it is. And then the final skill is how to use the macro lens, which we're going to talk about today as well. So some tips about setting up your apps and then general photography. Before we go on into some more detail, is to go through the options, the setup options for your apps. So there's some guides for common apps on the website. Take the case off your phone. Getting your phone close to the eye is key. In the same way as getting your ophthalmoscope close to the cornea is the key to a good fundic view in close direct ophthalmoscopy. So even a few millimeters of your case can actually make a difference between a good or a poor photograph. Third tip is to use a cloud storage service, such as Google Photos or Apple Photos. So there's several others on the market as well. And if you could get your cameras apps to automatically upload to the cloud, then even if you lose your phone or break your phone, you'll know you've got that critical photograph, be it of your patient or of your family. Think where your light is. Your pupils shape are different in your different species. In cats, they're obviously vertical slit pupil. In horses, it's a horizontal pupil, and rabbits, it's also a sort of it's a vertical oblate pupil as well. And these size patients, nucleated eyes and training models, and euthanized pets as well are all really useful ways of training to be able to see the fundus and with a still patient. So a few more tips about the app itself is make sure you try and save most camera apps will have what's called a camera roll, which is a way of saving the focus within the app, rather than to the actual phone itself. And that's important because if your app becomes corrupted or gets deleted by accident, you may lose images. You can change the maximum image capture resolution on most apps, so you want that as maximum as possible. And if you have the option to record in RAW, RAW, then that will also give you even more detail. Most camera apps have either touch to focus or touch to set exposure settings, where you tap the screen either to focus but also to show it where you want to expose it as well. So learn how to use those. Volume snap is available on most camera apps. That means you use the volume, the up or down volume switches to take a picture rather than just the button on the screen. Having geotagging turn on helps, particularly if you're seeing equine cases or large animal cases, because you actually remember where you took the photograph, which is helpful when you're trying to remember find the picture of a dog you took at that branch surgery last month. If you have the option to have live exposure on your camera app, that will display shutter speed, ISO, etc. That's really helpful because that will help you decide if you're struggling to get a good photograph. Maybe it's pixely, for example, then it may be because your ISO has been automatically turned up by the phone camera, which you didn't realise. So displaying your live ISO and shutter speed will help you know whether or not you need to add in extra illumination. And if you can select full manual mode, that will allow you to focus yourself rather than waiting for the camera to autofocus. That can be really useful, particularly when you're looking at lens features. For all your patients, we try and do standard views, which is very useful for making sure we don't miss things out. It's useful to try and identify the patient, so often photographing the clinical record screen, try and get a picture of the whole patient, the whole face, looking towards us, aiming to get both tapetum reflections. So we look at the lid anatomy with the eyes open, closed. We induce a blink, we invert the eyelids, look at the inside of the eyelid margins, a good place to look for lumps and bumps and extra hairs, and then we prolapse the third eyelid and photograph that. We then look at each eye on its own, and we get them to look straight towards us. We aim to zoom in with digital zoom so it fills the entire screen with tapetum reflection, and we chat to the patients while doing this to get that particular view. And then we try and look from the side to get a lateral view, aiming to skylight the corneal curvature and the anterior chamber, which you often repeat immediately as well. One of the issues we have is that the phone lights are very, very bright. That's very useful because it allows us to dazzle our patients, for example, to see whether they are visual through a cataract. But it's often too bright for them to tolerate. looking at the fundus or even the lens. So you need some way of reducing the light intensity, either with a diffuser and 2 or 3 layers of microscope tape, maybe all you need to use. You can use, some apps will allow you to reduce the actually within the software allow you to reduce the brightness. So Pro Camera is the one which I use for that reason. And also you can use physics. If you can move your phone further away from the patient, then you will also dim the light, but also you also reduce your resolution as well. So a practical session, this is for you to try at home, maybe after this lecture, is to try and sort of get some smartphone basics. So the first task is to learn how to focus. So you want to focus very close to you on the text, or once it's a piece of text, it's usually a very good thing to use on the table in front of you. And you want to get the camera as close as you possibly can while still remaining in focus. And then you want to move the camera away and focus at the furthest point in the room. And then if you can then try and get a view with the focus with the table in front of you and the furthest part as well, practice auto-focusing by tapping on the near field and then on the far field. If you have manual focus, then this is the time we're going to use to try practice that as well. Some camera apps have a macro setting. The macro setting isn't really a macro setting, but what it will do is it will automatically fix your closest focal point as close as you possibly can, and it will often do some digital zoom to enlarge the image for you as well. So thinking more about that minimal focal distance, your second task is after you've got the hang of how to focus, is to identify how close your smartphone can get to an object and still remain in focus, your minimum focal distance. So this is a photography chart we use for testing lens quality, so it's quite a nice thing to be able to just focus on something with really fine detail, get as close as you possibly can, and while it still remains in focus, and then to work out how many centimetres that is from your patient, and remember that minimum focal distance, and then if there's no point getting closer than that, because it will always be able to focus. The third task is to take the whole head photograph of a human friend or animal patient if you have one with you. Try and take 2 images of their face, so it's filling your camera, one with the flash on and one with no flash at all, and one with the phone in torch mode with the light on continuously, which we can do using video if need be, but ideally you'd have installed an app which allows you to do that. You want to focus on the eyes, and you want the patient looking towards you, so tap to focus, talk to your patient, say look straight towards you, and then examine the photograph looking for asymmetry in the whole eye, so pupil aperture, third eye position, pupil size, shape, and look at reflections. Look for corneal reflections, which do a lot about corneal pathology, particularly where the image without the light, the unlit image, and then the lit image, you should be able to see the red reflex if you're a human patient, or the blue or green reflex if you're an animal patient. See if you can zoom in and see any opacities in the illuminated images. Finally, your final task is to do distant direct phoneoscopy, if you like, so to mimic the distant direct technique using your phone. So we can get you to turn your camera light on, either using the camera app with the light torch mode, which allows you to do that, or the video mode with the light on if you haven't got a camera app. Have your phone about a foot from your patient, from your colleague, and you want to see if you can get the lovely red reflection. And once you've got the red reflection, you can use digital zoom to zoom that facial image so that both eyes are in your image. Once you've got that image of the red reflection, you can then assess and record by using video or signature photographs the pupillary light response. So move the light away and then move it back again, and you should be able to see the pupil constricting in response to the light. Once you've assessed your pupillary light response, then each eye in turn, you want to get your phone as close as you can to the patient, whilst still maintaining that fundic reflection, and then zoom in, see if you can get the pupil to fill the entire screen. And then once you've done that, you try experiment by changing, going from side to side to look for peripheral fundic reflection changes, but also if there are any opacities, whether they move. So, an example of how we can use distant direct in our patients and how powerful a tool it can be. I'm going to run through a few cases. This patient on the left has got corneal reflection, so we can see a beautiful straight corneal reflection from the room lights. This is in our clinic with overhead UV lights. So having normal corneal reflections tells you that the front of the cornea is usually healthy. So to have a healthy corneal reflection, you need a healthy tear film and a healthy epithelial surface a healthy and intact epithelial surface to support that tear film. So yes, it's great. It's got lovely corneal reflections. We can see there's some corneal opacity, there's some grey areas and some red areas. When we turn the light on, these corneal reflections disappear. We retain some of the corneal reflections from the upper eyelashes, but now we can see that highlighted against the beta reflection, these blood vessels. We can also see that this area here, which corresponds to the grey area over here, is actually quite transparent. So rather than being full of cells, so an area of infiltrated cornea, this is actually an area of corneal edema where light is able to pass through, but appears blue from the side. So the patient moved another keratectomy, so again with the light off, we can see the dorsal cornea is normal. You can see the reflection of the phone and myself and my colleagues, my hand. You can see the computer screen in the background, but as we get to the bottom half of the cornea, those corneal reflections are completely disrupted. And this is where the anterior cornea has been removed with superficial keratectomy. We turn the lights on, my corneal reflections disappear, so we can now see the size of the pupil, and we can use that pedal reflection to assess whether this area of cornea is commonly infiltrated. And I can see lots of light passing through this area of green stay cornea, and also see the epithelium is growing back over the edge of the keratectomy wound as the keratectomy starts to heal. Using video is really useful, particularly if you're looking for lesions deeper in the eye. This patient's got some vitreal changes. These grey folds here are degenerate vitreous. But in the moving image, we can see that as we move around, these sheets are actually mobile, which is something you can't really appreciate. As we change our angle, we become very obliquely. We see a lot more of these opacities. So using videos with the light on are really helpful as well, particularly for mobile lesions. Another example is a horse with grey cornea, just about making out the pupil and just about making out the corona analytica. And when we turn the light on, however, most of this blue area we can see is actually transparent, which tells us that blueness is more likely to be edema than infiltrate. Finally, this slightly denser area here, ventromedially, corresponds to areas of corneal opacity. And these are keratic precipitates, pieces of pus, inflammatory cells on the inside of the cornea. And this patient's got chronic uveitis, secondary glaucoma, which is why we have the generalised corneal edema. But for these two photographs, between them, gives lots of information which allow us to pass comment on what's going on inside the eye. So the next part of the talk is to talk about how we get much better close-up images to see some of the pathology in our patients. So we're going to talk about smartphone macro photography. Now, ophthalmologists are used to using this concept all the time. We use a slit-lamp microscope, which is a handheld microscope with an oblique light source, and we can look at high magnification structures in the eye from the front of the cornea to the anterior vitreous. We can mimic this technique using our smartphones with a little macro lens attached in front of the lens and either oblique light source using a pen torch or the on-camera light. To do this, you need to have a macro lens. These are cheap and readily available. They often sell them at the garage. when you go to get your petrol. If you, by choice, you want a black one because there will, of course, less reflections. You can get them built into the case, which is very useful. Times 10 magnification is fine for most things. Times 20 can be useful, but at times 20 you get such a narrow depth of field it can be quite hard to use. If you've got a coated glass lens, that also means that you'll get less reflections, and you want a nice small lens if you can, so that you, if possible, you can still use the camera light. This is the one that I tend to use most. It's the Apex L 12 times 24 times macro lens. It's got a glass lens, it's coated, that's why it's got an orangey purple view colour, which reduces reflections. You have two lenses stacked one on top of the other. If you use both together, it's times 24. Most of the time we take the outer lens off and just use the smaller lens. And these are very reasonably priced, and can give you amazing images. Most of my macro photographs will be taken using this particular type of macro lens. This is just a reminder as to why we want a black lens. This is a horse with an iris cyst. Dogs and cats have them as well. This is before surgery, and this is after surgery. We use a laser to ablate them, and you can see individual melanocytes floating away into the vitreous. But this big white annoying ring is because we have a silver macro lens, which you can still see the pathology, but with a black macro lens you get you get less reflection. So this is a case fitted lens. You can get case with them fitted, which is very convenient. One thing to sort of bear in mind is this distance between your camera and the light. If it's too close, which is very useful for distant ophthalmoscopy, when you put your camera lens, your macro lens on, you'll see it will get in the way of your on-camera light. Some of these cameras, some of your phones with multiple lenses are actually much easier to use because you can put your lens over here, still use your on-camera light. If you're going to use to do this technique, you're going to need to be able to select which lens you want, and your native camera app won't always let you select the lens you want to use, but this third-party camera app often will. So that's another reason for getting a third-party camera app. These are all a series of iPhones, just again to illustrate the iPhone 4, how close they are together, and it's a big difference in all these phones. And if it's a long distance like the 7 Plus, you can use the macro lens on the lens and still use the on-camera light. But this with the iPhone 6, this is too close and it gets in the way. So often losing that of the on-camera light isn't as big a problem as you might imagine, because having light obliquely is actually often more useful than having light in the same direction when you're doing macro photography. I like using one of these head torches with variable brightness and also the ability to focus, and that can be very useful light. What's called a modelling light to illuminate the image for your macro photography. So this is very different. So this is the same phone. We're either using a light from the side, or just a pen torch in this case. And if you see, when we look at this picture of the iris, how beautifully three-dimensional it is, because light's coming from the side. We can see the anatomy of the iris. We can see the individual stromal, the blood vessels, the folds in the iris stroma, and the three-dimensional appearance of the granular indigo. When we use the same phone but use the light which is on the camera itself, we can still get a lovely photograph, but it's much less three-dimensional. But it's also a bit easier to use. You don't have to fiddle around holding the light. So we often prefer to use modelling lights. Will give you a much more three-dimensional view, but the on-phone light is easier because you don't have to manhandle a second instrument. And it's just again to remind me, this is exactly how the still lamp works. So we use the magnification here and our light obliquely from the side. So we use the still lamp, we rely on oblique illumination to get the three-dimensional view of our patient's eyes. In order to to focus high magnification, you're going to need to be able to support your camera with as many points of contact as possible. So you often need a little bit of finger yoga to try and do that. So my first image, I'm using my 2 fingers to support myself against the horse's head, but also holding the camera, and my right hand, I'm using my knuckle on the horse's head. So it's in this right hand image, I'm actually resting my phone on my thumb, which is holding against the horse's face. So you can get a bit creative about how you hold your phone, will help you get better images too. Once you've got a nice image, you can then zoom in, use digital zoom to see detail, check you're in focus as well. So you can reach very high magnifications using a combination of your digital zoom and your optical zoom on your macro lenses. And so this lovely image on the left-hand side is a stacked image showing an iris melanoma. And this is the tear film in the lower lid, and as we're going in and out of focus, it's like the waves washing up on the seaside. So it reminds me how what a real structure the tear film is. It's not just a hypothetical structure. This right-hand picture is a picture of a contact lens and a corneoscleral transplant we've done in a cat. So this bottom half here is transplanted cornea. The top half with the blood vessels is the conjunctiva, which is part of the same graft, and the dark area is the limbus, which started its life up here. You can practice your macro photography. What I do, particularly in the summer, is to take my highest magnification macro lens, 24 lens, and a pen torch into the garden and try and find the smallest eyes I possibly can. And this is just using my iPhone, and actually I can get almost a microscopic view of these beautiful eyes of this little flesh fly. So finally, we're going to think about how we use our phones to image the fundus, the retina. And we can do that either using indirect techniques to image the image produced by the lens, the left-hand side, which in dogs and cats through undulated pupils is your technique of choice. Do this in dogs and cats. Without a lens, you're going to have to have a fully dilated pupil. We can see a beautiful image of a cat. This is direct view, and this dog again a direct view through dilated pupils. And this right-hand image is from a baby alpaca cria. So direct fundoscopy and indirect fundoscopy. So direct fundoscopy, we're getting the phone really close to the patient. This is a rabbit, and a little video showing its optic nerve head and radiating to people, radiating nerve fibre layer, or indirect fundoscopy, where you're imaging the lens. Thanks to this already. So the field of view would be shown by the camera. So if you have 2 lenses, telephoto and a wide angle, once you've got a close direct view of the retina, you can change your lens and you'll get a smaller field of view, but obviously a magnified image. So close direct is about getting your phone as close as possible to the cornea, and you can see from this side image we're less than 10 millimeters from the cornea in order to get a good fundic view. You can start to see the fundus further away than that, from probably 30 millimeters away. You'll start to see the fundus. This is an alpaca again, a baby alpaca cria, and from about 1.5 inches away we can still see the adnexa, we can see the pupil, but we can see this optic nerve. And as we get closer, we will see more of the retina, and as we get closer again, we can see more again. We can still see some of the pupil, but this is the money shot. This is what we're aiming for. We're aiming to get close enough that there's no longer any view of the pupil, but then we can see the maximum view of the fundus, and this beautiful ungulate retina. You can see the retinal vessels curling around each other, which is typical of many ungulates. So this is a little video just showing it in action. So we're going to use manual focus to focus infinity. So here we go on the left hand side. So as you can see the sliding up and down. And we want to focus infinity, which is the same as the 0 setting in your ophthalmoscope. And then we can use what's called focus peaking with this particular app, where when you tap the screen, it will actually do a little digital zoom for you, and then we can change to a second lens. We change to the ×2 lens now to get a closer view of the retina. Right. So that's a quick overview about how to use the cameras as a clinical tool. Before we finish, we're quickly just going to remind ourselves of why it's important to look at the eye, and then we'll give you a quick final overview reminder about how to take good photographs. So distant direct is useful in all your patients, particularly in corneal disease. This is a dog which has got a rough cornea because it's got an ulcer. It's lost its corneal reflection. We can see that without any fluorescein stain. And then when we turn the light on, we can see not only is it an ulcer, but it's got this area of infiltrate around. And this is a stromal abscess form. This is an infected corneal ulcer. It's just about to melt. And we met this patient earlier. He's about to have his corneal cross-linking. So this patient's asleep now. We looked for a distance. We saw this ring of infiltrate, which worried us it was going to be full of cells or bacteria or both. We took him to surgery. The epithelium is falling off, and this area of cornea you can see is starting to go yellowy. And we then used corneal cross-linking to both sterilise the cornea to kill bacteria, but also to relink the corneal lamellae, which were starting to separate and become very edematous, to try and save this cornea without having any surgery. For cataracts, it's distant direct is our key tool. And we can, particularly if we start moving around, we can get ideas of anatomy. You can see this left image. We see the edge of the nucleus, and within the nucleus this opacity. This is a normal lens, but actually you can see that the central part of the lens looks different to the more equatorial parts of the lens, and that's a normal aging change, nucleus sclerosis, that happens in all patients. And there's a small focal cataract at the front of this patient's lens here. So this, when you have cataracts or opacities at the level of the pupil, this is just beneath the anterior lens capsule, so it's at the level of the pupil. What you'll notice is as you move around, this opacity will remain in the same position, same relative position to the pupil margin. Whereas this is a nuclear cataract, so further away from the pupil, and as you move around, you'll see this opacity will change position relative to the pupil. And just a reminder again that looking for vacuoles at the equator of our lenses are something we want to do to rule out progression of cataracts. And when you suspect posterior disease, then distant direct is vital. So this is a gift from Receiver's wonderful manual. It's a cat who's blind due to retinal detachment, and we can see big dilated non-responsive pupils. You can see very quickly with distant direct. This is another cat with hypertension. She's got blood in the front of her anterior chamber, and you can see that without the light up. If the light was turned off and you lost that tapetum reflection, you'd still see this clot. But with the light on a camera or distant direct, when we look at the tapetum reflection, you can see the tapetum reflection is changed. It's not yellow, it's a red colour with a darker red at the bottom, and that tells us there's actually blood in the posterior chamber. So this is there's blood in the dorsal vitreous, and there's a large clot in the ventral vitreous. Obviously, if it's total hyphemia, you don't need distant direct to see that. So it's another example of posterior change. There's no hyphemia in either of these patients, but there are either lots of bleeding in the vitreous with a total red out, a red reflex, or in this case we've got smaller amounts of hemorrhage. It's a very quick test, distant direct with our phones or ophthalmoscopes, and we should be able to see these changes. And finally, when the retina attaches completely and comes forward, you'll actually start to see retinal vessels without the ophthalmoscope. So just from the naked eye, from distant direct. So if you can see retinal vessels like this, then that tells you that retina's now come up behind, right towards the back of the lens, so the total bullet detachment. So ophthalmoscopy really does save lives. For your any cat over 7 to 9, you should be doing distant direct, and ideally looking at the fundus to look for early hypertensive lesions. And one of the frustrating things about posterior segment disease is that often we don't see it clinically until it's severe and often irreversibly, so either when the retina is detached or the back of the eye is full of blood, unless you look with the ophthalmoscope. With your distant direct, your close direct ophthalmoscopy, it's very easy to miss posterior segment lesions. So learning to use the diagnostic lens is a very important skill. However, posterior segment disease is relatively rare, except for feline systemic hypertension, which Siva have done great works to try and increase our knowledge and the profile of this disease. So it's very common to find evidence of systemic hypertension in the eyes of older cats. When you do see inflammatory posterior segment disease, it's rare. When you do see it, it's often a sign of life-threatening systemic disease. So again, an important reason to look. So ophthalmoscopy saves lives. A few other examples before we finish. Dogs also get systemic hypertension, and dogs and cats with bleeding clotting disorders can present with retinal bleeding or hyphema. Feline TB, we often present to us as total retinal detachment, and then a few less common diseases such as feline pulmonary adenocarcinoma can cause choroidal infarction, which is very striking. This is a cat with TB. We see the retinas pushed forward, and this is actually this is the retina come away. This is actually the tapetum, and this is the sclera. And between the tapetum and the sclera, this is all mycobacterial abscesses. And this is actually the same eye after enucleation. We can actually see this is the back of the eye here, the sclera. This is these horrible abscesses we're seeing between the retina and the back of the eye. And finally, just a reminder of your breeds. So remember your basset hounds and your springers, particularly primary glaucoma is common. So red eyes, so red sclera, and blue eyes and corneal edema. You need to be worried about with glaucoma. And the other breed to think of with glaucoma, your terrier breeds with primary lens luxation. And nowadays, if we catch it early enough, we can remove the luxated lens and replace it with a sutured artificial lens, which can give these dogs an excellent long-term prognosis. So just a quick reminder about how to take photographs for you to take away. During COVID, we relied on telemedicine a lot and lots of photographs. So we set up, with the help of one of our colleagues, Matt Dobson, a little website just to remind to help our clients take better photographs. But it's a useful tool for us to use. Is Matt at the clinic with some of our other colleagues, Kat and Jules. And if you follow this link at the bottom, preconsult.rovets.sport, then it quickly runs through very simple aid memoir how to take a photograph. So first thing is to keep the room dark to reduce your corneal reflections that we haven't mentioned. They can be useful. We want to make sure you turn on the flash. We've talked about how we want that ideally on all the time, but having your flash is very important. If you then have someone to help hold the patient, that makes it a lot easier. Keep your distance, as Matt's put it, so make sure you don't get closer than your minimal focal distance. Keep the eye central, so talk to the patient so they look towards you. That'll help get that tapetum reflection as well. And use your hand to gently open the eyelids, so not too close, but just a little bit of gentle tension, an inch or so from the lid margin will be enough to keep the lids open. And take lots of photos, and then go back and find the best one. You can also take videos and pause and then take a screenshot of the video as well. So summary, keep the room dark, keep your flash on, have someone to hold you, make sure you're not too close, keep the eye central, get a nice open lids and multiple photographs. That's the end of today's session. Thank you for listening. Any questions, please message, email, phone anytime. We'd love to have visitors at the clinic and happily show you how to use your phones and get more out of both using your ophthalmoscope and your phones looking at your clinical patients. Thanks for your time today.